Hi, my name is Professor Dr. Somshekhar. I'm a Global Director for Aster International Institute of Oncology and Chairman of Medical Advisory Board Aster DM Healthcare. In cancer, we are always worried that the treatment is more dangerous than the disease. That the surgeries are so big, we would cut open the whole body, the chest, the tummy, we'll have a lot of pain, they lie down in ICU, hospital for weeks together, then they will take a lot of time to be able to eat, to overcome the pain, then repercuting the home would take months together. This would not only cause a lot of pain only to the patient, loss of revenue from their work, and the whole family members are tied up. This was actually partly true many decades before, because cancer surgeries are very major complex surgery. That's why the advancement in cancer happened, which is a robotic surgery. What is robotic surgery? There is an advanced, very advanced computerized forearm machine which a surgeon uses. Robot means it is not that surgeon is somewhere robot would do. No. Robot is a modified, advanced, computerized forearm device surgeon would use and wear to do this surgery. What are its advantages? It has got forearm with endorist technology, enables surgeon to go beyond his human power and natural disability of human being to perform complex surgery. The robotic camera has two cameras which magnifies 12 times, so I can see where is cancer, where is nerve, where is vessel, where is the normal part, what is the functional. And the robotic arms are multitasking. They have got ICG, they have got laser, they have got a monopolar, various factor. To add to this, their very stable platform, huge magnification with 3D stereoscopic vision, surgeon sits and operates. So you are comfortably operate. What it translates? It translates into quick surgeries, very precise surgeries, painless to very minimal pain and discomfort, fastest recovery, no need to usually go to ICU, same day you can walk, eat everything, usually in 48 hours to 72 hours you are back to home, in 1 week you are back to your work. Yet giving very good cure rate in cancer, not compromising. So where are these robotic surgery beneficial in cancer? Foot pipe, esophageal cancer. You don't have to cut the chest. Lung cancer in the chest. Practically a surgery which takes long time to do and do in ICU, people go home in 48 hours. Rectal cancer surgery in the deep pelvis to preserve the sphincter, avoid permanent stoma. Prostate now preserving cancers. Gynec cancer, uterus cancer, cervical cancer. Kidney cancer to preserve kidney. Colon cancer. Also thyroid cancers for transaxillary scarless and mouth torse. So various places, urology, gynecology, rectal cancer, pelvis, then stomach cancer, colon, rectum, it's a big boon. Now Aster International Institute of Onco, CMI and Whitefield unit, our group has done the largest number of robotic cancer surgery, more than 5,000. The largest group, practically every day 4 or 5 we have. We are a training center for everybody. This is a center of excellency as judged by the International AIIO Society, that Aster CMI and Aster Whitefield are the center of excellency for robotic surgery. Over 5,000 patients have got benefit of this surgery and they've gone home smiling with good cure with minimal discomfort. So ask your doctor, look at yourself, are you eligible for robotic surgery? Don't deny this benefit for your loved one and a cancer patient. Not only cure, but also quality, least discomfort, quick return to home. Thank you very much.
Breast cancer is preventable, detectable, treatable, and also curable. Hello everybody, this is Dr. Rohit Kumar, Consultant Surgical Oncologist at Aster International Institute of Oncology, Aster Hospitals, Bangalore. Today, I'll be talking and going through few highlights about breast cancer, particularly in Indian setup. Breast cancer is a problem in India because it is the topmost cancer across both the sexes. Nearly 1.8 lakh cases are diagnosed every year, out of which 80,000 of them are dead. That is more than 50% mortality. That's a very sad thing for us. So, why is this such a big problem? What is the most commonest causes? What can we do about it? The causes related to breast cancer can be modifiable or non-modifiable. The non-modifiable causes are being a female itself, age, and also familial or genetic causes. Modifiable causes, which is under our limits, are to have a healthy diet, have good physical activity, and to lactate and have children on time. Now, let us look into some common symptoms with which we can diagnose or get evaluated for breast cancer. The most commonest symptom is a painless lump. Apart from painless lump, we also can see nipple discharge or skin changes. How is a breast cancer patient evaluated? It is usually done by triple assessment, that is, examination by the doctor, evaluation by imaging, that is mammogram, and then biopsy to confirm the diagnosis. So now, when we talk about prevention, as I already mentioned, it is very important to consider 4 pillars of health. That is the healthy diet, then physical activity, good sleep, and also how we manage our stress. Talking into detection, most important thing is early detection. That is the key for cure. For early detection, we always advise and tell to practice self-breast examination. It is about knowing your breast well. It involves feeling and seeing. You feel for your breast and look into any abnormal or normal things and get evaluated if you feel any abnormal symptoms or signs. Treatment of breast cancer involves surgery, radiation, targeted therapy, and also hormone therapy. Surgery, as I am a surgical oncologist, surgery in breast cancer has moved more towards organ preservation. More breast conservation surgery is being done with sentinel lymph node biopsy to prevent arm lymphedema. So to wind it up, I would tell breast cancer is detectable, treatable, preventable, and also curable. Stay informed to stay healthy. We at Aster International Institute of Oncology are here to treat you well and to take care of you well. Thank you.
Hello, my name is Dr. Anup P. I am consultant hematologist at Aster Hospitals, Bangalore. Let us have a brief look at blood cancers. So cancers in general can be broadly divided into 2. One is the solid organ cancers and the other group is hematological cancers, which can arise from either the blood, that is leukemia, or lymph node, which is lymphoma, or the bone marrow, which is multiple myeloma. These hematological cancers together are sometimes known as liquid tumors, and this is to differentiate them from solid organ cancers, which arise from organs such as kidney, lung, breast, pancreas, and so on. Now, blood cancer is actually technically leukemia, and leukemias can be of 2 types again. One is acute leukemia, which is rapidly growing and life-threatening, and the other group is chronic leukemias, which are slowly growing. Acute leukemias and chronic leukemias will usually respond very well to medications, that is chemotherapy or immunotherapy. So modalities such as radiation and surgery are not usually required for hematological cancers. Of course, there are exceptions. In acute leukemias, the cure rate is inversely proportional to the age of the patient. So the best cure rate is for preschool children, followed by older children, followed by adolescents, followed by young adults, and followed by middle-aged people, and so on. In adult patients with acute leukemia, often after clearing the disease with chemotherapy, they will require a bone marrow transplantation in order to achieve a long-term cure. In chronic leukemias, usually we don't need strong or intensive chemotherapy. Usually it will be lighter treatment, which is usually on outpatient basis, and most of the time it will be tablets, sometimes injections. Now, both these acute and chronic leukemias will respond very well to treatment. And just one word about the other types of hematological cancers, that is lymphomas and multiple myelomas. So they are also very sensitive to treatment. Most of them can be either controlled long term or even cured. So that is in brief about hematological cancers, especially the blood cancers. Thank you. I'm Dr. Girish Shetkar, head and neck surgeon at Aster CMI Hospital, Hebal, Bangalore. Head and neck cancers are one of the commonest cancers that we encounter in our country. It's the sixth leading cancer worldwide, and about 60% of the cancers of these cancers are seen in Asia. And 30% of all cancers in India are head and neck cancers. And of head and neck cancers, oral cancers are the most common cancers that we see. About 1.2 lakh oral cancer cases are diagnosed every year, and about 72,000 patients succumb to oral cancer every year. So, head and neck cancer is usually a cancer of the upper aerodigestive tract, which involves the lip and oral cavity of the mouth, or the nasopharynx, which we call it as the upper part of the throat, or the oropharynx, so the mid portion of the throat, or the hypopharynx, which is called the lower or the bottom portion of the throat. And also the voice box, or the larynx is what we say, and the tumors of the salivary glands or the nasal cavity, and paranasal sinuses or the thyroid glands. The commonest cancer that we encounter in head and neck region is the squamous cell carcinoma, and these cancers that we encounter are usually diagnosed by doing a proper clinical examination, which involves a visual inspection, examination of the mouth, of the oropharynx is what we say, and also the neck examination, along with endoscopy procedures when required, either a nasal endoscopy or a video laryngoscopy that is usually done. Along with a visual inspection and examination, a physical examination, we would also take help of by doing a biopsy, and also do certain cross-sectional imagings, which is usually a CT or a PET CT or an MRI scan, and in certain instances even a simple ultrasound scan is of good help. Once we have diagnosed the case, then it comes as staging it. So the staging is where the imaging, the clinical examination, both are as part of the clinical staging, where this staging is usually from stage 1 to stage 4. Stage 1 and 2 would comprise of it being an early stage cancer, and stage 3 and stage 4 would be an advanced stage. So essentially, an early stage cancer would involve only a single modality treatment. It can either be with surgery or possibly radiation. And in advanced stage, it's usually a combination of two: surgery followed by radiation, and certain instances, radiation followed by surgery, especially if it has to be salvaged after initial failed treatment. And when you come to surgery per se, especially in oral cancer, surgery is the mainstay when it comes to oral cancer management, especially in a curative stage. And surgery would involve essentially three aspects. It is the removal of the tumor, what we call as resecting the tumor, and also addressing the regional lymph nodes or the neck lymph nodes which are removed, and then also doing an appropriate reconstructive procedure. So all of these procedures are done at the same time on the same day for the patient. And then is about rehabilitating the patient with his speech, swallowing, with his chewing functions, and then also ensuring that there is a reasonably acceptable aesthetic outcome as with your reconstructive procedures that you can give to these patients. Oral cancer or head and neck cancers, what is the cause for it? If you look at the cause for it, is usually tobacco in any form, usual forms being the chewable form or the smoked form. Especially in our part of the world is the chewable form. They are available in various forms, as in betel quid or pan masala or gutka, and various other names that are there known. And the smoking form, usually the bidi or a cigarette, and also one would see e-cigarettes or cigars in hookahs in urban places. So when you have, along with tobacco use, there's also alcohol use. It would act as a synergistic effect, and the possibility of the propensity of somebody developing cancer would be that much more higher. Along with these two well-known risk factors that we have known over the years with tobacco and alcohol, there are other factors like human papilloma virus is what we say, which usually causes oropharyngeal cancers, more commonly seen in the western part of the world, and the nasopharyngeal cancers, which is caused by the Epstein-Barr virus. And the other causative agents being poor oral hygiene, or a diet which is lacking in fresh fruits and vegetables, or a weakened immunity are some of the other causative factors when it comes to head and neck cancer. And head and neck cancers, as we know, the actual cause for it, so it's at least the oral cancer is something which is a preventable cancer, because oral cavity, as we know, is an accessible part of the human body, where one can think of detecting some of these cancers at an early stage. And early detection of these cancers will help us in providing simple treatment which would be cost effective for the patient, and also would amount to limited morbidity related to treatment. And the aspect of oral cancers also have something called as a pre-cancer or a pre-malignant stage, or oral potentially malignant disorders, which would essentially tell us that if not picked up at this stage, there is a propensity for these lesions to transform into a malignancy. So that's again sort of a warning sign that one would have, or the patients can also look by themselves doing a mouth self-examination, and we would essentially be able to sort of have them abstain from the tobacco use, and also have them on a regular follow-up. And once you do a proper surveillance of these patients, you can actually prevent malignant transformation of these commonly seen lesions in our part of the world. So at Aster CMI in Head and Neck Oncology Department, we have all of the services that are required in managing head and neck cancers with proper well-equipped OT and department for surgical management, and also the radiotherapy and the chemotherapy treatments, which are also essential parts of head and neck cancer management, along with a good pain palliative medicine department.
Hi, I'm Dr. Girish. I'm a consultant surgical oncology here at Aster Hospitals, Bangalore. I'll be speaking about pancreatic cancer. Pancreatic cancer is quite an uncommon cancer compared to the other commoner variants, other parts of the body. It's an uncommoner one. But it's been a dreadful one to have. The presentation is usually at a later stage because of its intricate area, the involvement of the surrounding structures. It's usually a delicate or a dreadful one to have. Patients usually ask for what are the symptoms, common symptoms. The common symptoms usually are painless jaundice. Suddenly there is some jaundice, a short history of jaundice. There would be no fever or a recent history of any infections, no, nothing of that sort. Suddenly they present with jaundice, a short history, just about 2-3 weeks. They have been having loss of appetite, they don't feel hungry, they don't eat well, there is a significant weight loss. All these things should definitely make you to visit your physician or come to our hospital, Aster Hospitals here at RV, CMI, or at Whitefield Hospitals. We have a set of our surgeons, including us, radiation and the medical oncology team, to take care of your needs. The other most important symptoms would be backache. Patient usually presents with backache. This is usually a locally advanced thing which presents as backache. The earlier we detect, the earlier the patient can definitely go to curative treatment, as these things usually have a propensity to involve locally important structures, including the blood vessels supplying the intestines, the main blood vessel which takes the nutrients to the liver. All these things are involved as the stage proceeds further. So the earlier the patient presentation, the better is for the patient and for the treatment. So these symptoms should make us visit a physician of your choice or come to our hospital. At this place, we take care of all your surgical, medical oncological and the chemotherapy requirements and the radiation requirements according to the stage of the patient. Even our palliative care team over here takes care of the appropriate patients which are not part of a curative or other sorts of treatment. So please, I would suggest you to keep in contact with your physician for further treatment and visit us. Thank you.
Hello, I'm Dr. Beliappa, radiation oncologist from Aster Institute of Oncology, Bangalore. Today I'm going to introduce about the precision radiation oncology, what we practice in Aster hospitals in Bangalore. So today I will tell you what is this precision radiation oncology. Any cancer treatment, the main stay of treatment is surgery, radiation oncology, and medical oncology. We deal with the radiation oncology, and the radiation is given by two means. One is teletherapy, the other one is brachytherapy.
Both teletherapy and brachytherapy can be complement to each other. So with some cancers we use only teletherapy, some we use teletherapy followed by brachytherapy. This teletherapy, when we give, we want to make sure we treat the tumor only. We have to respect the normal tissue. This teletherapy can be given for any tumors. For example, we can treat brain tumors, head and neck cancers, thoracic tumors, then we treat abdomen and pelvic tumors. So when you treat these things, there are a lot of normal tissues will come in the way of the tumor bed or in and around that area. So we have to respect the normal tissue when we treat this tumor per se or tumor bed. So it's a big challenge. How do we treat these things? In Aster CMI, we have excellent facilities. We have a machine called TrueBeam, and we use these facilities to treat a specific technique, like in what we call IMRT, IGRT, SBRT, and these are the different techniques we use it so that we hit only the target and we respect the normal tissue. The advantage of this giving a precision radiation oncology is where we respect the normal tissue, we can avoid the early or maybe late complications, especially in head and neck areas where we expect a lot of mucositis, and these things can be minimized with helping this precision radiotherapy. We can avoid dryness of mouth and we can allow the normal tissue to recoup faster. Especially in gynec malignancies, we get a lot of cases here in India. We use this precision radiotherapy where we treat only the tumor bed and we avoid the normal tissue like the bladder and the rectum, where we can avoid not only the early reactions and the other late complications like chronic cystitis and chronic proctitis. And especially the other common malignancy we get here in Aster hospitals is prostate malignancies, which we are getting in very early diseases, where radiation has got a major role to play after the hormone therapy, where we give precision radiotherapy, where we can avoid the normal tissue to the maximum. So with all this precision therapy, what we practice here, we are getting a good outcome of the result. That is, the cure rate is very good. And the best outcome is like, we can avoid the normal tissue so that avoid the complications of radiation induced. To know more about this radiation, precision radiotherapy, you can come in, walk into Aster Institute of Oncology in Bangalore, so we can discuss more about it and get the best of the treatment. Thank you very much.
I am Dr. Raghuram. I am a pediatric hemato-oncologist at Aster Group of Hospitals, Bangalore. Today I am going to speak about a common disease called thalassemia. Thalassemia is a hemoglobin disorder where there is a genetic mutation and there is an abnormal hemoglobin which leads to breakdown of this red blood cells which carry oxygen around the body, and the children develop anemia. Children usually become symptomatic at around after the age of 6 months. They usually present when the child develops a fever or a cough and cold and becomes very pale, and when they are taken to the doctor, the doctor will do a blood test noticing the pallor, and the child is found to have severe anemia, and on examination the child may have an enlarged liver and spleen. And then they will get to do a blood test called hemoglobin electrophoresis, which will confirm the diagnosis. Most of these children with thalassemia major will need repeated blood transfusions, where they need blood transfusion every 3 to 4 weeks. And they need to get these blood transfusions lifelong. And it is very important to get NAT tested blood so that they do not get any infections because of the blood transfusions. Because of repeated blood transfusions, there will be an increased iron levels in the body, and this iron can get stored in organs like heart, liver, pancreas, and cause problems. So to reduce the amount of iron in the blood, after about 10 to 12 transfusions, they will be started on medication to reduce the iron levels, and they need to take these medications regularly lifelong. With this treatment, most of the children will lead on to have normal lives till about 30 to 40 years of life, but they will develop complications usually after this age. So the only curative treatment for this, which will get rid of the disease, is the bone marrow transplant. And this is usually done, we will get the best results when it is done from a matched brother or sister. And when there is no matched brother or sister, we can do the transplant from an unrelated matched donor or from the parents who will be half match, called haploidentical transplantation. And post transplant, these children will lead on to have normal lives and will get rid of the disease and will not need any medications about 6 months to 1 year after the transplant. The bone marrow transplant can be done at Aster group of hospitals in Bangalore, and we have got a dedicated bone marrow transplant unit, and our team has done more than 250 transplants for thalassemia with very good results.
What you see is what you get. If you don't see, then use an appropriate tool to be able to see. Hello everyone, I am Dr. Ram Alva, consultant radiation oncologist at the Aster International Institute of Oncology. Today I'm going to be speaking to you on something known as image guided radiotherapy, or IGRT. Now this is a specialized technique which is available in the state-of-the-art linear accelerators. This allows us to visualize or see, like I said, using an appropriate tool to identify if what we had planned for the patient is being delivered in that patient. Now, we need to remember two important principles of radiation oncology. One is to give maximum dose to the tumor and minimize the dose to the surrounding structures. And second one is that we should be able to reproduce this treatment on a daily basis over many weeks of treatment. IGRT is a tool with which we will be able to achieve both these important principles together. Now, what are the problems we face on a day-to-day basis while we are treating our patients? The patient might not be in the same position that he or she was on the first day of planning. And second, even if they are in the same position, the tumors tend to move inside the patient, especially while they are breathe or when they have bowel or bladder movements, which kind of complicates the treatment. With IGRT, we are able to minimize both these complications and deliver the appropriate treatment to the tumor, as well as minimize the dose to the normal structures. How is it done? It is done when the treatment team takes few images of the patient just before or during therapy. We match these images with the images that we had taken prior to therapy, and if any movements are noticed, we provide the appropriate corrections. Sometimes the doctors may also suggest placement of some small dots or fiducial markers in the tumor or right next to it, so that these dots can be picked up while we do this imaging to give us a good imaging perspective of the tumor. Another way is to place some markers on the skin surface, which is also acts as a surrogate for picking up the movement of the patient inside the body. Which tumors are the IGRT technique is indicated in? Nowadays, as oncologists, we try to include IGRT in most of our cancers, but the more appropriate areas where we can include them is lung cancers, prostate cancers, the upper abdominal hepatobiliary or pancreatic cancers, gynecological cancers, as well as the gastrointestinal cancers, and sometimes even in the brain and spine tumors. Sometimes we are using very high-end technology such as the RAPIDAC or VMAT or the stereotactic radiotherapy, where I think IGRT is the more appropriate treatment modality that has to be used. In Aster CMI, as well as in the Aster hospitals in Bangalore, we have the high-end medical instruments such as the Variant TrueBeam, as well as the Electa Versa HD. Both of these instruments have onboard imaging and allow for IGRT usage across board. So please, if you want to have any further discussion on this technique, you can approach us at the Aster International Institute of Oncology. Thank you.
Hello, I'm Dr. Sai Vivek, Consultant Medical Oncologist at Aster Institute of Oncology, Bangalore. Today, let's discuss briefly about hereditary breast and ovarian cancers. 15% of the most common cancers in our country in women, that is breast and ovarian cancers, are due to hereditary causes. The main characteristic amongst these are they tend to occur 1 decade early compared to the normal age of occurrence. So in case the normal breast and ovarian cancers occur at 60 years, the hereditary part of these occur at the age of 45 to 55. And 15% of the breast and ovarian cancers are usually attributed to hereditary causes again. Now, why is it so important for us to know about these? So there is usually clustering of other cancers in a person who's carrying these genes. So like prostate cancer, pancreatic cancer, uterine cancer can also be part of the same spectrum. So when do we suspect and how do we diagnose? So we suspect a hereditary cancer when there is clustering of the cancers like breast, ovary, prostate, endometrium, that is uterine cancer, in a particular family. And in a particular patient, if a breast or an ovarian cancer occurs before the age of 50, our suspicion goes up. And if there are 2 cancers occurring in the same person, again we suspect hereditary cause. If there is a person with male breast cancer, it becomes another indication for testing. Or if there is a known relative who's positive for this particular hereditary genes that we attribute these to, we again have a high degree of suspicion. So the main genes involved here are the BRCA genes, that is BRCA1 and 2, which is more common. Then we also look at the genes concerning the Lynch syndrome and other rarer genes like STK1 and P10, which also form the spectrum of hereditary breast and ovarian cancers. So how is it important for us in terms of patient management? So there is a new tablet which can be used post the treatment of these cancers as a maintenance or even as a treatment in advanced stages to give better survival rates and to screen the other family members and pick up who are already carrying this gene and start screening 10 to 15 years before the standard screening procedures, so that we are able to pick up these cancers at an earlier stage and offer them higher than 90% cure rates. And there are also risk reductive surgeries which can be done above a certain age, where you eliminate the risk of this cancer coming by almost 90 to 95%. So for more information about hereditary breast and ovarian cancers, please see us in our OPD at Aster Institute of Oncology, Bangalore. Thank you.
Hi, I am Dr. Stalin Ramprakash. I am one of the pediatric hematologist oncologists working at the Aster CMI hospital. Today I am going to talk about bone marrow transplant. First we'll start with what is bone marrow. Bone marrow is a sort of material which is inside the bone, which is like a factory which makes all the red cells, white cells and platelets in the blood. So whenever there is a problem in the bone marrow, then we do the treatment called bone marrow transplant, otherwise also known as stem cell transplant. So bone marrow transplant, how we do it and why we do it, I will explain to you. Bone marrow transplant is done when there is a diseased marrow, defective marrow or non-functioning marrow, where we want to replace the stem cells which are not working from the patient with new stem cells which may be working. So the bone marrow transplant, we sort of classify them into 2 main types, which is called autologous transplant and allogenic transplant. Autologous transplant is when you use the patient's own stem cells to correct the problem. Most of the time this is used in cancers where the normal amount of treatment is not sufficient in solid cancers. So one of the side effects of giving large amount of chemotherapy is that your bone marrow will fail. So in order to avoid this, we collect the patient's own stem cells first and freeze it or store it and then give the medication and then give the stem cells back to them so that we can give a higher dose of chemotherapy. Another situation where this may be used is some severe autoimmune conditions where we want to sort of switch off the immune system and reset the whole thing. So that is also another situation where we will use autologous transplant. Majority of the other transplants are allogenic transplant. So when we say allogenic transplant, it is done from somebody else. So either it can be a matched brother or sister, or it can be another unrelated person, or in some such situations where the transplant is necessary but you cannot find a donor, we may use from either parent or sibling who are half matched, which we call as a haploidentical transplant.
So what are the conditions in which we do the bone marrow transplant? So I already told about the diseased, defective and non-functioning marrow. Diseased marrow is when, say for example, there is a leukemia. Most of the leukemias will be cured with chemotherapy, but there are a group of leukemias which may not be responding well to the chemotherapy. In those situations, we need to do a bone marrow transplant. Or defective marrow. So when there is a genetic condition, for example, conditions like thalassemia, sickle cell, where the patient is born with a genetic defect, then in order to correct the genetic defect, we cannot use the patient's own cells, so we use somebody else's stem cells, then which will make the normal cells, then it will correct the problem. So this will become a curative treatment for many conditions which are otherwise non-curable. Say for example, thalassemia and sickle cell are the conditions which affect the red cell, which can be cured with bone marrow transplant. And there is a whole number of primary immunodeficiencies where the white cells are not functioning, where we will have to use the stem cells from a donor so that you can correct the defect. Otherwise, their life is very, very limited. Similarly, there are some platelet disorders like Wiskott-Aldrich syndrome where we will do a transplant to correct the problem. And how do we do it? Usually, that this is not a surgical treatment. So we have to be clear. So whenever the word transplant is used, people imagine that it is going to be a surgery. This is not a surgery. This is a medical treatment. And one good thing about the treatment is that compared to other solid organ transplant, the donor actually doesn't lose anything. They have to give some stem cells, which your body will make. So the donor doesn't lose anything. Another important aspect is if the treatment is successful, they will not be on any long-term medications. Whereas as opposed to a solid organ transplant, either liver or kidney transplant, they will have to be on lifelong medication. Whereas bone marrow transplant, when it is successful, you come off every single medication and you live a normal life. And how do we do it? So in order to prepare the patients for the transplant, we may have to give a lot of medications. Most of the medications are similar to the drugs which we use in cancer therapy, or otherwise known as chemotherapy, and some immunosuppressive therapy. So we give these medications to remove the patient's own bone marrow and also reduce the patient's immune system so that they will accept the cells from the donor. And usually the admission will be for about 1.5 months, so 10 to 12 days or 15 days before the transplant and about another 2 weeks, 3 weeks post-transplant. So this is a serious procedure, but it is always used in severe life-threatening conditions. Without this procedure, the patient's life may be very limited or very little chance without this procedure. Lots and lots of people are now benefiting from the bone marrow transplant. At Aster CMI Hospital, we have a very experienced team who has done many number of transplant and a full equipped bone marrow transplant unit and nurses. So we will be able to take care of any condition needing this procedure.
Hi, I'm Dr. Vaishnavi Joshi, medical oncologist, Aster CMI Bangalore. I'm here to talk about targeted therapy in medical oncology. Medical oncology is a fast evolving field of medicine. So we treat cancers with therapies like chemotherapy, targeted therapy, hormonal therapy, immunotherapy. So what is targeted therapy? Before we go into understand what is targeted therapy, we should know what are targets. So targets are gene rearrangements or gene mutations, or it could be overexpression or amplification of any of the gene mutations seen in cancer cells. These targets are diagnosed by molecular techniques, which could be a polymerase chain reaction, or it could be a FISH, or a comprehensive genomic profiling. So once we find these targets, these can be explored to use these cancer therapeutics called targeted therapies. So they only address the cancer cells which are tagged by these targets and have less collateral damage to the surrounding normal tissues. So hence we have improved outcomes and increased efficacy with reduced side effects. And cancer therapeutics called targeted therapies could be small molecules like oral drugs to intravenous drugs called monoclonal antibodies. They do not have the side effects which are seen in conventional chemotherapeutic agents like hair loss, nausea, vomiting, diarrhea, etc. So with these targeted therapies has opened a new era of cancer therapeutics where we are seeing excellent outcomes in our patients, especially in stage 4 cancers, by minimizing side effects and improving the efficacy. So here in Aster Hospital, Bangalore, we are doing high-end molecular biology techniques to find out all these targets and using these targeted therapies to help plenty of patients, especially in the stage 4 cancers where people think it's a death sentence, and improving outcomes day in and day out. Thank you.
Hello, I am Dr. Pratima, radiation oncologist from Aster CMI Bangalore. Today I am here to talk to you about IORT, which is intraoperative radiation therapy. So what is this intraoperative radiation therapy? It is basically a type of radiation treatment in which the tumor or the tumor bed is exposed at the time of surgery. So how does this help us? It helps us in directly visualizing the tumor bed, the surrounding normal structures, and precisely delivering the radiation dose. In doing so, we are able to deliver high doses of radiation precisely to the target area while spacing out the normal tissues away from the region. The advantage of this modality is that compared to external beam radiation, we do not have to wait for a period of 4 to 6 weeks for delivering this treatment, and it can be done in the same sitting as that of the surgery. And as compared to external radiation, we reduce the risk of delivering radiation to the normal surrounding structures. IORT can be delivered by various modalities such as electrons, X-rays, and brachytherapy radiation. In early cases of breast cancer with very favorable features, in the operative setting itself, catheters are placed in the specific portion of the breast where originally the tumor was found, and then the region of the breast is treated over a short duration of time. In case of soft tissue sarcomas, recurrent abdominal tumors, and even certain recurrent gynecological cancers, the delivery method can be via electrons or X-rays. In conclusion, IORT, intraoperative radiation therapy, is a highly effective method of delivering the radiation precisely to higher doses to the target tissue while minimizing the doses to the surrounding normal structures. Kindly contact the radiation department for further queries.
Hello everyone, I am Dr. Sunita, radiation oncologist working at Aster CMI Hebal. Today I will be talking to you regarding intraoperative electron radiation therapy. Intraoperative electron radiation therapy, or IOERT, is a specialized technique of delivery of radiation where we will be using linear accelerator which is stationed in the OT operation theatre itself to deliver a very high dose of radiation to the tumor bed. Intraoperative electron radiation therapy, we will be delivering the radiation in the operation theatre. So both the surgeons and the radiation oncologist will be working together here and then delivering the treatment in the operation theatre itself. Once the surgeon removes the tumor bed will be irradiated to a very high dose of radiation. Usually intraoperative radiation, electron radiation therapy is a single session of treatment, and it can be as such delivered as a primary modality of treatment, or it can be an add-on to an external beam radiation. The major advantage of delivering intraoperative electron radiation therapy is directly here we will be visualizing the tumor bed, and we can retract the critical organs away from the radiation field, and we can even block the radiation to the critical structures by shielding them. So in this way we will be delivering high dose to the tumor bed and decreasing very minimal radiation to the surrounding normal structures. And the subsequent visits to the hospital because of the adjuvant radiation therapy can be reduced here. The number of sittings of hospital visit can be reduced eventually. So the major advantage of intraoperative electron radiation therapy is it is very precise, A single session of treatment which can be delivered in operation theatre itself, minimal delivery of radiation to the organs in the surrounding structures. In that way, it is going to be highly precise. Thank you.
Hello, I'm Dr. Darshan, working in Aster International Institute of Oncology, Aster CMI, as a consultant surgical oncologist. So I am here to talk about thoracic malignancies, which is the utmost significant topic in the present times. So thoracic malignancies are cancers which encompass a range of organs which arise in the thoracic cavity, the chest cavity, including the lungs, the esophagus, the thymus, or the pleura. Out of all this, the lungs are the most commonly affected organs and the most popularly known organ, and unfortunately it is the deadliest as well. So what are the causes of lung cancers? Usually there is a cellular damage at the DNA level which gets mutated, and this mutation grows into a larger cell which grows it as cancer. Any mutation or growth happening in the thoracic cavity leads to thoracic malignancies. And there are certain risk factors as well. The most common risk factors are the smoking, and second-hand smoking in an individual where a person is not smoking but surrounded by people who are smoking, and workplace carcinogens, people working in asbestos industries, people working in mines, people working in glass industries are more prone to malignancies, thoracic malignancies. How can we prevent thoracic malignancies? It is usually the early detection and avoiding exposure to carcinogens. Okay? And usually it is detected with imaging and with bronchoscopies and with multiple imaging and symptoms. Usually the symptoms are cough with expectoration, breathing difficulties, and breathing with exertion. And coming to the treatment aspect of thoracic malignancies, there are multiple treatment options like surgery, chemotherapy, targeted therapy, immunotherapy. In each case, the treatment options are different, and it should be personalized to a particular case depending on their age, stage of the disease at presentation. So in Aster CMI, we treat thoracic malignancies in a robotic option, and we treat all the other malignancies in the abdomen, pancreas, the pelvic malignancies, along with thoracic malignancies. Any metastatectomies can be done in Aster CMI.
Hello, my name is Dr. Vinay Bhatt. I'm a consultant surgical gastroenterologist and GI oncologist at Aster CMI Hospital, Hebbal. Gastric cancer or stomach cancer is the 5th most common cancer across the world. The number of patients being diagnosed with gastric cancer is on the rise. This rise can be attributed to several factors, including obesity and dietary factors. Patients who are obese have a much higher risk of developing gastric or stomach cancer. Patients who consume a diet rich in processed foods, salted or smoked foods also have a very high risk of developing gastric cancer. In addition, alcohol, smoking, H. pylori infection, and a strong family history also contribute to an increased risk of stomach cancer. The early symptoms of stomach cancer are often non-specific and can mimic common conditions such as reflux disease, peptic ulcer disease, stomach or duodenal cancer. The symptoms that we commonly associate with gastric cancer include jaundice, abdominal pain, blood in the stools, vomiting, or weight loss. Unfortunately, these symptoms usually represent an advanced stage of gastric cancer. The treatment options for gastric cancer depends on the stage at which it is diagnosed. In early stages, the treatment could be endoscopy. In advanced stages, the treatment would involve surgery, chemotherapy, or radiation, or a combination of all of these. Staging or diagnosis of gastric cancer can be made with an endoscopy and scans, which would include a CT scan or a PET scan. The outcome of any patient depends on the stage of the tumor and the amount that it is spread. Slow-growing tumors have a good prognosis. Fast-growing tumors have a poor prognosis. Tumors that have spread have a poor prognosis. Tumors that are picked up at an early stage have a good prognosis. In order to stage these tumors, like I mentioned earlier, we do an endoscopy, which would involve passing a pipe down the throat into the esophagus or the food pipe, into the stomach and beyond, to look for whether there are any ulcers, nodules, or abnormal areas. Sometimes we do advanced endoscopic techniques such as narrowband imaging to screen these patients to see whether they have early gastric cancer. We can also stage patients with gastric cancer with imaging such as CT scan or PET CT. These tell us how much a tumor has spread, whether it is spread to local organs or to distant organs. Based on this staging, we would offer treatment to patients who have been diagnosed with gastric cancer. The treatment options include endoscopic treatment, surgical treatment, radiation, or chemotherapy. Surgical treatment of gastric cancer involves removal of a part or the whole of the stomach, along with the lymph nodes to which it is spread. This surgery can be done robotically, laparoscopically, or as an open procedure. The choice of surgery would depend on the stage and patient-related factors. As a patient, you would need to visit a GI oncologist if there is a strong family history of stomach cancer, if symptoms are persisting beyond 2 weeks despite traditional treatment, or there are multiple risk factors for gastric cancer. To conclude, with multidisciplinary care, gastric cancer is curable.
Hello, I am Dr. Aaron Marin Fernandez. I work as an associate consultant in the Department of Surgical Oncology in Aster International Institute of Oncology, Aster CMI Hospital. Cancer screening tests help to find cancer or precancerous areas early. Sometimes these tests find things before you may even have symptoms. Cancer treatments are the most successful when cancer is found early. For example, during your routine dental examinations, your dentist should look at your mouth and tongue for any changes. This is a small form of oral cancer screening. Males in general should also be screened for prostate, testicular, colon, and skin cancers. If you are a smoker or have a history of smoking, you may also want to have a lung cancer screening. Some general cancer screening recommendations for males. Prostate cancer screening. Always talk about the risks and benefits of prostate screening. Screening tests include a small blood test in the form of prostate-specific antigen, PSA, and or a digital rectal examination. If you have had a brother or a father with prostate cancer before they were 65, you should consider about prostate cancer screening at the age of 45. Also discuss about your risk of familial prostate cancer screening and genetic testings. Testicular cancer screenings. Most testicular cancers happen between the ages of 15 and 45. Get familiar with the look and feel of your testes. Report any changes, swellings, lumps, bumps, or any abnormal discharge. The easiest modality of screening is by getting an ultrasound of the testes. Colon and rectal cancer screenings. There are many different types of screening tests used. Individuals at an average risk for colorectal cancers should begin screening at the age of 45 years. Now, when I say average risk, it means you have no personal history of colorectal cancer or polyps. You do not have a family history of colon cancer. You do not have a history of ulcerative colitis or Crohn's disease. And you do not have or suspect any family hereditary colorectal syndromes like familial adenomatous polyposis or HPNCC. An individual at an average risk for colon and rectal cancer is screened usually by stool for occult blood and getting a full-length colonoscopy after the age of 45 years to up to 50 years. Lung cancer screenings. Most people do not need lung cancer screenings. There are some people who are screened for lung cancer because they are at a higher risk because of their smoking history. Screening is done with a yearly low-dose CT scan of the chest. You may be eligible for a lung cancer screening if you are 50 to 80 years of age and in fairly good health. You smoke now or you have quit within the past 15 years. You have at least a 20-pack year smoking history. Now a pack year is the number of cigarette packets you have smoked each day multiplied by the number of years a person has smoked. So for someone who has smoked a pack of cigarettes per day for 20 years, he has a 20-pack year smoking history. Smoking cessation counseling is as important as screening. Skin cancer risk. Skin cancer is very common and the rates of skin cancer continues to rise. You may find skin cancer early by knowing your skin and your body, looking at birthmarks, moles, and freckles. If a mole has changed in size, shape, or color, if it is bleeding or it itches or is scaly, please go to your nearest doctor and get your skin tested. We recommend every year for a wellness checkup for all males. During this visit, you should or you may be screened for some cancers. Your doctor will talk to you about your family cancer history and if you have any genetic mutations that put you at a higher risk for some of the cancers. This will ensure that your doctor has a plan for you when and how often you need to have a cancer screening. For this topic and further information regarding cancer screening in males, you can always come to Aster CMI Hospital to the Department of Surgical Oncology at Aster International Institute of Oncology. Thank you.
Cancer, as we all know, has a devastating effect on human body. But with recent advances in research, there are a lot of preventive measures. We can identify it early and treat it. This is what constitutes preventive oncology. Today, I'll be briefly discussing about the preventive measures for cancers affecting the women's reproductive organ, namely the cervical cancer, the ovarian cancer, and the uterine cancer. So the first one would be the cervical cancer. So what is cervix? Cervix is the lowermost part of the uterus or the womb, and the cancer affecting that is the most common gynec cancers. So one woman dies every 8 minutes due to cervical cancer, and almost all of these cases are caused by a sexually transmitted infection called the human papilloma virus. So not all infection causes it, but only a few high-risk strains, namely the HPV 16, 18 goes on to produce cancer. But the good news is we can completely prevent this infection from happening. How do we do it? Yes, there is a vaccine called the HPV vaccine. It's nearly 90% effective in preventing the infection if administered to a girl before her sexual debut. So based upon the recommendations, HPV vaccine can be administered for girls from the age of 19 years as 2 doses for up till 14 years and 3 doses later on. And the second good news is cervical cancer has a very long latent period, that is about 15 to 20 years from the infection till the cancer development. So here comes the importance of screening. So what is screening? So these are a few medical tests or procedures which can be applied to a woman who's completely normal without any symptoms at a regular interval so that we can identify precancerous and cancerous lesion at the earliest. So for cervical cancer, we have effective screening, that is pap smear and the HPV testing. So this has to be done by every girl or woman beyond 25 years and if she's sexually active up till 65 years of age, either by a pap smear once in 3 years, or the preferred is the pap plus HPV testing once every 5 years. It's a very simple office-based procedure done in about hardly 5 minutes. So what if it is abnormal? Nothing to panic. We have a further diagnostic test called the colposcope, where the cervix, the vagina is examined under magnification. If any abnormality detected, we can take a sample for the testing. So the second cancer is the ovarian cancer, which is the most lethal among the gynec cancers. It's also called the silent killer. Why? Because nearly 75% of the women present at an advanced stage. So what do we do so that we can prevent it? Though we cannot completely prevent the cancer from happening, but there are certain behaviors which whereby we can reduce the risk. So if anybody has a high personal or a family history of ovarian cancer, breast cancer, colon cancer, we can advise them to go for genetic counseling and to identify if there's any mutations like the BRCA1 mutation, BRCA2 mutation. If so identified, there are provisions of prophylactic surgery, that is surgery which can prevent the cancer from happening. I'm sure all of you would have heard about Angelina Jolie undergoing surgery, that is prophylactic breast removal, ovarian removal, when she had this mutations known. Similarly, the other behaviors like breastfeeding or having a tubectomy once the family is completed, or the birth control pills reduce the risk. And in those women who are at a higher risk, they can go for screening by the annual surveillance with a tumor marker or this blood test called the CA125 and an annual ultrasonography. So the third cancer which I would like to talk is the uterine cancer, also called the endometrial cancer or the cancer of the uterine lining. So this is a lifestyle dependent cancer. Means women who are obese with other comorbidities like diabetes, hypertension, who have high cholesterol levels, this places a woman at a higher risk. Though there is no effective screening method, but these women usually present at a very early stage. What does that mean? That means usually if any postmenopausal women who has a bleeding or a spotting, or women who are approaching menopause but who have irregular bleeding or a very high bleeding, they have to report to a doctor immediately. We at Aster have facilities called a flexible hysteroscope, where we can look into the uterine lining, identify if there's any abnormality, and take a sample, which brings about very little discomfort to the patients. So I would like to conclude my today's topic by an age-old saying, prevention is better than cure. So I would like to emphasize that knowledge is power. So all women need to be aware, they have to understand their risks so that they can go for annual surveillance or screening, and that is the most crucial point. So we at Aster International Institute of Oncology, with our team of experts, we sit down with the patients. We have also the facilities for the latest screening, prevention and treatment modalities, novel surgeries for both the precancerous and the cancerous surgeries. Thank you.
Hello, this is Dr. Pushpanaga Seth, a radiation oncologist working in a Aster Groups of Hospital, Bangalore. So today I'm talking about a brachytherapy. So what is brachytherapy? Historically, the brachytherapy means a placement of a radioactive material inside the or near the tumor. So depending upon the placement of the radioactive material, brachytherapy, it can be classified as a superficial or the surface mode, where it is placed outside the body, or it is put into a natural cavity or the lumen. It is also called as an intracavitary, intraluminar or intravascular type of brachytherapy, or it is placed into the tumor tissues. That is called as an interstitial brachytherapy. So Aster CMI equipped with the brachy machine called as a flexitron, which is capable of delivering a very high dose of radiation therapy in a shorter duration of time. The brachytherapy procedure, it starts with a placement of a applicator or a needle or a catheter into the tumor or the cancerous tissue, near the cancerous tissue, followed by which the treatment planning CT scan will be done, where we map out the tumor and we will be accurately delineate the target area, and we have a dedicated TPS planning system which will actually calculate the exact duration and the dwell time of each radiation active material. So followed by the treatment will be delivered over a shorter period of time. The advantages of the brachytherapy includes a delivery of a very high dose of radiation to the tumor as compared to a sharp dose fall off to the surrounding normal tissue, and it is delivered over a very shorter duration of time. This application of brachytherapy, it has been included in the various cancer sites treatment guidelines, including the gynecological malignancies, the cervical, endometrial, the vulva and the vaginal cancers, the cancers of GI malignancies, including biliary tract tumors, the esophagus and head and neck cancers, the breast cancers and the skin cancers. To conclude, brachytherapy, it is a more precise treatment option in the cancer care, and it is an indispensable part of a radiation therapy. It forms an integral part of a treatment guidelines of the various cancer sites as mentioned above. For any further more information and queries, contact the Department of Radiation Oncology, Aster Groups of Hospitals, Bangalore. Thank you.
Cervical cancer is preventable, detectable, treatable and curable. Namaste Bengaluru. I am Dr. Rohit Kumar, Consultant Surgical Oncologist at Aster International Institute of Oncology, Aster Hospitals, CMI, Bengaluru. So, why should we know about cervical cancer? What exactly is cervical cancer? Let me go through this. Cervical cancer is the cancer of the cervix, which is also in general language the mouth of the uterus. Now, what is the problem? All over the world, nearly 6 lakh patients are diagnosed of cervical cancer. In India itself, every year, nearly 1 lakh people are diagnosed of cervical cancer. But the problem is not at all that. The problem is, out of 1 lakh people, nearly 60,000 people are dead by that end of the year. This is the problem statement why we need to know about cervical cancer. A cancer that can be prevented, that can be treated, that can be detected very early and you can be cured of. Cervical cancer and HPV infection. What is HPV? HPV means human papilloma virus. Yes, human papilloma virus infection causes cervical cancer. Nearly 95% of the cervical cancers are caused by HPV infection. So, who can develop HPV infection? In simple words, anyone who is sexually active can develop HPV, human papilloma virus infection. If you are having sex with a single partner or a multiple partner, if you are involved in sexual activity for one time or multiple times, all these things can lead to develop HPV infection. So, any person who is sexually active can develop HPV infection. So, does that mean all the people who develop HPV infection will develop cervical cancer? No. It's the same as telling all the people who got COVID infection will die. It's not, right? All the viral infections can be fought by our body's own immunity. So, even HPV virus is also like that. Anybody who has got a persistent HPV infection in their body, that will go on to become a cervical cancer over a period of around 8 to 10 years. This is the time we get to screen and detect if any cancer is developing in the patient as early as possible. The most commonest high risk virus of HPV are 16, 18, 31, 33, 35, 52 and 58. Apart from cervical cancer, they are also responsible for causing 80% of vulval cancers, 50% of penile cancers, genital warts, oral cavity cancers and also cervical cancers. So, HPV viruses can cause lot of genital organ cancers. Be aware to know about it. Cervical cancer, the most commonest cause, HPV virus, because of which the cancer is caused, it can be prevented. So, how can we prevent cervical cancer? It is HPV vaccination, human papilloma virus vaccination. Just like how we all gave COVID vaccination to prevent the COVID infection, similarly we have HPV vaccination to prevent infection of HPV virus. Because of the vaccination, the persistent infection of HPV is prevented and body gets ability to fight the infection. So, what are the types of vaccination? Who should get the vaccination? Now, that is the question to ask. HPV vaccination, the most commonly used vaccine is a quadrivalent vaccine, which has got vaccination against 4 high risk viruses, that is 6, 11, 16 and 18. What is the ideal age for HPV vaccination? the ideal age for HPV vaccination is between 9 to 14 years. It can also go and extend from 15 years to 26 years. The idea is the kids or anybody should be vaccinated before they are sexually active. That is when the vaccination will work best. So what is the schedule? The standard schedule of HPV vaccination is for all girls and boys between the age group of 9 to 14 years. 2 doses, one at day 0 and other 1 month later. If somebody undergoes vaccination in between the age group of 15 to 26, then they will require 3 doses. That is, first dose at 0, second dose at the end of first month and third dose at the end of 6 months. The efficacy of HPV vaccination for people aged above 26 years is not so great. It has to be taken only after discussion with your physician. HPV vaccination is safe. In fact, Government of India in another year or two is going to make this in along with the proper national immunization schedule as well. So get vaccinated to prevent HPV virus infection and then to prevent cervical cancer. Cervical cancer can be detected even before the cancer has happened. Is it possible? How is it possible? Yes, cervical cancer is detectable at very early stages or in pre-malignant stages itself. How is it done? That is the principle of HPV screening. As I told, HPV infection persistent for more than 8 to 10 years or for longer years can cause cervical cancer. This time duration that is needed for a persistent infection to then become a low-grade problem and then to become a cancer, this time is utilized for screening. So, what is the screening protocol? HPV or cervical cancer screening is to do what we call pap smear. Who should undergo pap smear? What is the schedule? So, all women under the age of 21 years need not undergo any screening. Between the age group of 21 to 30 years, every once in 3 years, you should undergo a pap smear. From the age of 30 up to 65 years, you can either undergo a pap smear for every 3 years or you can undergo a pap smear plus HPV DNA testing for once in 5 years. So remember, don't fear your pap smear. 5 minutes of your time for 5 years of peace of mind. Get screened with cervical cancer screening by pap smear. Cervical cancer is treatable and is curable if detected in early stages. So, what all is involved in treatment of cervical cancer? Any patient who is diagnosed with early stages of cervical cancer can sometimes undergo even fertility sparing surgeries also. So, 3 modalities which are used for treatment of cervical cancer are surgery, chemotherapy and immunotherapy and radiotherapy. We at Aster CMI hospitals, Aster International Institute of Bengaluru, we offer robotic surgeries, fertility sparing surgeries for early treatment of cervical cancer. Along with that, we also have a good multidisciplinary tumor discussion to plan the treatment for advanced stages of cervical cancer, which will involve chemotherapy and immunotherapy, the best of available for treatment of cervical cancer. And also, when it comes to radiation, we have the complete package of doing external beam radiation and also interstitial brachytherapy. which is a very essential component of treating cervical cancers. So remember, don't let the cervical cancer stop you. Prevent cervical cancer by vaccination. Detect cervical cancer earlier by pap smear. Treat and cure by the combination of treatment offered at Aster Hospitals, CMI, Bengaluru. Remember, get vaccinated, get screened, and then it's time to end the cervical cancer. Thank you. This is Dr. Rohit Kumar, Consultant Surgical Oncologist, Aster CMI Hospital, Bengaluru.